We will be starting the Luncheon Seminar 5, co-hosted by Reproductive. The topic is Challenge to Achieve 100% Fertilization Rate, the Future of ICSI Evolved by Assisted Sperm Fusion Inseminations, ASFI. Today, we have the honor of having Dr. Shirei Ohgi, President of Yanaihara Women's Clinic, as the chairperson. Dr. Ohgi, thank you very much.
Good afternoon, everyone. Thank you for joining Luncheon Seminar 5. This seminar is supported by Reproductive. I'm Shirei Ohgi. I'll be the host of this seminar. I'd like to welcome our speaker from Yanaihara Women's Clinic, Dr. Shota Hatakeyama. It's my pleasure to introduce our speaker for today. He received a bachelor degree in agriculture from Kitasato University in 2007 and a doctoral degree in medical science from Gunma Pass University in 2021. He is currently working at Yanaihara Women's Clinic as a laboratory director, where his research focuses on reproductive biology, specifically on sperm fusion insemination techniques. He is dedicated to advancing fertility treatments and improving patient outcomes through innovative scientific research. I have come to understand his personality very well. He is always hardworking and efficient, and he often does more than what is expected of him. Okay. He will give a presentation about a paper entitled Challenge to Achieve 100% Fertilization Rate, the Future of ICSI Involved by Assisted Sperm Fusion Insemination, ASFI. Please start, Dr. Hatakeyama.
So good afternoon, everyone. Thank you for all being here today. And thank you to Dr. Ohgi for the kind introduction. I'm deeply honored to share this stage with you. So first, I would like to express my sincere gratitude to the organizing committee, as well as Dr. Mokaran, Dr. Osuga, and Dr. Shirotani for giving me the opportunity to speak at this seminar. I would also like to extend my heartfelt appreciation to Reproductive and its chairman, Dr. Kuwayama, for their generous support in making this seminar possible. So, in this presentation, I would like to talk about our ongoing effort to achieve a 100% fertilization rate in microinsemination. This is a challenging goal, and we are continuously striving to reach it by developing a novel microinsemination techniques that enhances fertilization efficiency while reducing oocyte damage. So, what is the ultimate goal of infertility treatment? The answer is live birth. To achieve this, we must ensure fertilization, support embryonic development, and optimize conditions for implantation. Among these steps, I believe that ensuring fertilization is particularly crucial, because without fertilization, even the best oocyte can never develop into live birth. Now, imagine this. Right in front of you is a single oocyte. It is an oocyte you have seen many times before, an oocyte filled with immense potential. But this oocyte will never be obtained again. So, how will you fertilize it? How will you ensure that this life continues? For decades, we have relied on ICSI as a solution to address this challenge. ICSI has brought hope to millions and has led to countless births worldwide. However, it has also resulted in the loss of oocytes that carry the potential for life due to its inherent risk of oocyte degeneration. For over 30 years, we have continued to break the oocyte membrane, inject sperm, and pray it will not undergo degeneration. For years, we have overlooked the fact that some oocytes, each carrying the potential to become a human life, are lost because of ICSI. We have accepted this loss as an unavoidable side effect. I too have been part of this mindset, believing that oocyte degeneration was simply an unavoidable part of the process. Over years, I encountered numerous cases where the oocyte membrane broke, leading to degeneration at the moment of pipette injection. At the time, I attributed it to poor oocyte quality, assuming it was simply the fate of those oocytes. I thought there was nothing we could do. But is that really the case? Even the oocyte that seemed to destined degenerate during ICSI might become person if fertilization had successfully occurred. This means that every lost oocyte is a lost opportunity for life. Therefore, we should not simply accept oocyte degeneration as inevitable. Instead, we must strive to prevent degeneration while ensuring successful fertilization, even if fragile oocyte prone to degeneration during ICSI. That is why we must refine microinsemination techniques to maximize fertilization success and develop an alternative to ICSI. For patients who cannot achieve live birth with current treatments, this is not just about fertilization. It is about hope. It is about the possibility of life. So, with this in mind, let's take a look at today's agenda. First, we will explore how frequently this unfortunate degeneration occurs. Then, I will introduce the methods that have been attempted to reduce it. Finally, I will present a novel microinsemination techniques that has completely prevented degeneration. Now, let's move on to how frequently this actually happens in clinical practice. According to the ASFI guidelines, ICSI-related degeneration is evaluated based on two key thresholds. The competency value set at 10% or lower represents the upper limit of what is considered as acceptable degeneration rate in standard practice. Meanwhile, the benchmark value set at 5% or lower is the ideal target that reflects the highest technical proficiency and best laboratory conditions. This means that even in highly skilled hands, up to 5% of oocytes may still undergo degeneration. Despite our best effort, this reality remains. A portion of oocytes, each carrying the potential to develop into life, is inevitably lost as a consequence of the procedure. In my career spanning approximately 17 years, I've personally performed over 10,000 ICSI procedures. If I apply the 5% benchmark as a reference, that would mean I've caused degeneration in around 500 oocytes. So this may sound uncomfortable, but have you ever wondered how many oocytes might have been lost in your own hands? The exact number is difficult to determine, but when considering the global scale, an overwhelming number of oocytes have undergone degeneration due to ICSI. So, do you perceive this as small, or do you see it as something more significant? However, we have not merely accepted this issue without challenge over the years. We have continuously worked to understand and mitigate this problem. Next, I will provide an overview of the methods that have been explored to prevent degeneration. Several methods have been explored to reduce degeneration in ICSI. First, laser-assisted ICSI has been reported to minimize mechanical stress during pipette penetration through the donor pelster. In conventional ICSI, oocyte experience significant physical stress when the injection pipette penetrates the donor pelster. To address this, laser-assisted drilling creates a small opening in the donor pelster. This allows the pipette to penetrate with reduced force. This technique lowers the risk of membrane rupture and subsequent degeneration, ultimately improving oocyte survival after ICSI. However, this method does not completely prevent degeneration because a sharp-edged pipette is still required to penetrate the oocyte membrane for sperm injection. So next, piezo-assisted ICSI has been reported to minimize mechanical stress during injection. Unlike conventional sharp-edged pipette, the tip of the pipette used in the piezo system is flat, reducing the mechanical stress during injection. Additionally, piezo pulses generate rapid microvibration at the pipette tip, facilitating smoother penetration of the donor pelster and oocyte membrane with minimal mechanical stress. This technique lowers the force required for membrane rupture and significantly reduces the risk of oocyte degeneration. Indeed, several studies have confirmed that piezo-assisted ICSI results in a significantly lower degeneration rate compared to conventional ICSI. So while this method focuses on minimizing mechanical stress on the oocyte, another approach has been investigated not to prevent degeneration during ICSI, but to prevent it after ICSI. In oocytes with low stretch membranes, the olamer does not stretch sufficiently when the injection pipette is inserted. As a result, membrane ruptured without sufficient time for repair, leading to degeneration. To prevent this, one study proposed applying PVP immediately after removing injection pipette in cases where the oocyte membrane showed low stretchability. This increases osmotic pressure around the oocyte, inducing contraction and reducing membrane tension, thereby preventing oocyte degeneration. This study reported that degeneration rate was significantly lower in ICSI with PVP exposure compared to ICSI without it. Thus, various approaches have been explored to reduce degeneration and improve fertilization rates in ICSI. However, none of these methods have completely prevented degeneration. To fully prevent it, fertilization must be achieved without breaking oocyte membrane. So, is such a thing even possible? Yes, it is. Based on our clinical experience, we have applied a new microinsemination techniques to 450 oocytes, and not a single one has undergone degeneration. In the next part of this presentation, I will share the details with you. First, I will introduce the discovery and background of this microinsemination method. In 2020, we published that fertilization was obtained by pressing a donor pelster-bound sperm onto the oocyte membrane. We designated this novel microinsemination method as assisted sperm fusion insemination, ASFI. So you may wonder, how did we come up with this method? About 17 years ago, when I started performing ICSI clinically, I began to wonder, if it was possible to fertilize oocyte without breaking the oocyte membrane. I couldn't help but feel that the oocyte looked as if they were in pain during the procedure, and this concern made me question whether there could be a gentler approach. Then I recalled a microinsemination method known as SUSI, and I wondered if it could provide a less invasive approach to fertilizing oocyte. However, it raises a question: why was the fertilization rate of SUSI so low? SUSI is a microinsemination method that involves injecting sperm into the pelvic space. The official name is subzonal insemination, and it was introduced in 1988. I speculate that the low fertilization rate might be due to sperm moving freely within the pelvic space. Based on this speculation, to prevent sperm from moving within the pelvic space, I attempted to press the motor sperm head against oocyte membrane using an injection puppet. Since no photographs were taken at the time, this is a recreated image. The motor sperm was positioned here and held in place for about 1 minute. Then, after removing injection puppet, I observed the sperm head remained attached to the oocyte membrane while its tail was still moving. At the time, I thought I'd discovered an excellent method. However, when I performed the same method with other sperm, it did not work. Even though I extended the duration of pressing sperm to 5 minutes, the result was still unsuccessful. Consequently, it only worked on the first attempt, which made me think it was just a coincidence. So, at the time, I decided to give up and did not pursue it further. 10 years later, when I enrolled in graduate school, I decided to revisit the method. But first, I needed to ask a fundamental question: what is the difference between sperm that attach to the oocyte membrane and those that do not? To better understand the factors that enable sperm to attach to the oocyte membrane, I first reviewed the existing literature. As a result, all sperm that attach to the oocyte membrane have undergone an acrosome reaction. The acrosome reaction is a process begins with a partial fusion between the sperm plasma membrane and the outer acrosomal membrane. This fusion triggers the release of enzymes from acrosome. As a result, the inner acrosomal membrane becomes exposed. So there are various opinions on when this phenomenon occurs, but that is not the key point here. What matters is the fact that all sperm that attach to the oocyte membrane have undergone the acrosome reaction. This led us to crucial realization: if we could reliably secure acrosome-reacted sperm, it might be possible to fertilize oocyte without breaking oocyte membrane. But how can we secure the collection of acrosome-reacted sperm? To address this question, we built on the previous findings and hypothesized that the sperm bound to the outer layer of the oocyte, known as the zona pellucida, might also undergo the acrosome reaction. When we reviewed the literature, we found that several researchers reported that the acrosome reaction rate of sperm bound to the zona pellucida ranged from 22% to 48%. However, we suspect that these results were not accurate, because in those studies, sperm bound to the zona pellucida were collected by pipetting the oocyte. This collection method is insufficient to examine only the sperm that were completely bound to the zona pellucida. Some sperm that were dead or simply attached to the surface of the zona pellucida might also have been collected and observed. Therefore, we retrieved several motor sperm that were completely bound to the zona pellucida using an injection pipette and investigated their chromosomal status. This slide shows the subject and the method. Among the patients who underwent oocyte retrieval for treatment purposes during the period shown in the slide, oocyte and sperm that not were used for treatment due to lack of fertilization, immaturity, or degeneration after conventional insemination were subjected. Written informed consent was obtained from all the patients. On the day after conventional insemination, motor sperm bound to the zona pellucida of the target oocyte were collected using an injection pipette. In contrast, motor sperm not bound to the zona pellucida were observed as a control. This video shows a demonstration of the sperm retrieval technique. The opening of the pipette was positioned close to the tip of the sperm tail. Then, sperm tail was strongly aspirated while the pipette was positioned near the sperm head. At the moment the sperm detached, the pipetting suction was stopped. This slide shows the result. The acrosomal action rate of the GP sperm group was 19.8%, while that of the control group was 28.60%. A significantly higher acrosomal action rate was observed in the GP sperm group. Based on this observation, we speculate that it might be possible to fertilize oocytes using zona pellucida-bound sperm, potentially preventing oocyte degeneration, because breaking the oocyte membrane would not be necessary. To test this hypothesis, when we press the zona pellucida-bound sperm against oocyte membrane, they successfully attached. Up until that point, we had only succeeded once, but using zona pellucida-bound sperm led to success. So we confirmed that attachment was possible. But the next question is, will fertilization occur afterward? Moreover, for clinical application, how can we reliably secure zona pellucida-bound sperm? So next, we attempted to perform a microinsemination method using zona pellucida-bound sperm, which we designated as ASFI. In the previous study, we focused on oocyte after conventional insemination to obtain the zona pellucida-bound sperm. At our clinic, we perform rescue ICSI on unfertilized oocyte after conventional insemination as part of our clinical practice. Therefore, we performed ASFI on oocyte instead of rescue ICSI. We defined this process as rescue ASFI. Among the patients who underwent oocyte retrieval and conventional insemination during the period shown in the slide, rescue ASFI was performed on 89 couples who consented to participate in this study. In contrast, rescue ICSI was performed on 233 couples who either did not consent or did not obtain zona pellucida-bound sperm despite giving their consent. As a result, rescue ASFI produced comparable fertilization and blastocyst formation rates compared to rescue ICSI. Furthermore, rescue ASFI exhibited significantly lower degeneration rate. So based on this result, fertilization was successfully achieved without breaking the oocyte membrane. However, we observed some issues when the ASFI was performed on unfertilized oocyte after conventional insemination. These included the risk of polyspermy and uncertainty about the timing of sperm entry. In order to perform rescue ASFI, sperm penetration had been inferred based on these signs. Because pronuclei usually do not appear 6 hours after conventional insemination. This made it difficult to accurately determine whether the oocyte was fertilized or not. Sperm may have already penetrated during conventional insemination even if the oocyte was judged as unfertilized using these signs. Therefore, a risk of polyspermy was observed when performing ASFI instead of rescue ICSI. Moreover, it is not technically clear whether the oocyte was fertilized by sperm pressed against oocyte membrane or not. To address these concerns, performing ASFI on oocyte without conventional insemination is necessary. Therefore, in the present study, we aimed to investigate whether ASFI without conventional insemination can enhance fertilization and embryonic development compared to conventional ICSI. So I will now summarize what has been covered so far. First, we reviewed the zona pairs-bound sperm underwent the acrosome reaction. Then, fertilization was achieved by pressing these sperm on unfertilized oocyte after conventional insemination. However, this study alone is sufficient to fully demonstrate ASFI's usefulness. Therefore, next we will explore how ASFI compares to conventional ICSI in clinical outcomes. This prospective study was conducted on sibling oocyte. In this study, we utilized immature or degenerated oocyte to secure zona pairs-bound sperm. Patients with the inclusion criteria of retrieving at least 2 metaphase to oocyte, 1 immature or degenerated oocyte, and absence of a severe male infertility conditions were recruited. Consequently, 24 couples undergoing 34 oocyte retrieval cycles were included. Written informed consent was obtained from all patients. After oocyte retrieval, cumulus oocyte complexes containing metaphase to oocyte were incubated exclusively. In contrast, COCs containing immature or degenerated oocyte were incubated with 10,000 motor sperm. After incubation for 2 hours, the cumulus cells were removed by pipetting. Subsequently, these oocytes were incubated with sperm for an additional hour to enhance the number of sperm bound to the donor pasta. In contrast, cumulus cells surrounding metaphase to oocyte were removed using hyaluronidase. Subsequently, metaphase to oocyte were alternately allocated into conventional ICSI and ASFI. If the number of metaphase to oocyte was odd, the surplus oocyte were assigned to the conventional ICSI group. In the ASFI group, after aspirating motor sperm bound to the donor pasta, the sperm was pressed onto the oocyte membrane. This slide shows a demonstration of ASFI. The zona pasta-bound sperm was already aspirated into the injection pipette. The pipette was then used to penetrate the zona pasta. Subsequently, the sperm head was pressed against oocyte membrane using the bevel of the injection pipette for 10 seconds. Finally, the injection pipette was gently removed without interrupting sperm motility. After removing injection pipette, we observed the sperm remained attached to the oocyte membrane with its tail moving. The tail movement gradually stopped. Using a time-lapse system, we were able to observe sperm incorporating into the oocyte. The sperm is attached here. As shown, sperm had gradually incorporated into the oocyte over time. This slide shows fertilization outcomes. The 2-pro nuclear rate of ASFI was 18.8%, while that of the conventional ICSI group was 17.2%. A significantly higher 2-pro nuclear rate was observed in the ASFI group. Moreover, no oocyte degenerated after ASFI, resulting in a significantly lower degeneration rate. The next slide shows outcomes of embryonic development. There are no significant differences observed in the rates of good embryo formation day 3, blastocyst formation, and good blastocyst formation between the two groups. However, the usable embryo rate was significantly higher in the ASFI group. So based on these results, ASFI had several advantages. The first and the most remarkable advantage of ASFI is its ability to fertilize oocyte without breaking the oocyte membrane. In ICSI, despite decades refinement, including the introduction of PASO method, it has remained extremely difficult to eliminate degeneration, since the process inherently involves membrane disruption. But in our study, not a single oocyte has undergone degeneration. This is a groundbreaking result, as we has overcome one of the most critical and persistent limitations of ICSI, oocyte degeneration. The second advantage of ASFI is that only sperm are incorporated into the oocyte without additional substances. In ICSI, substances other than sperm, including media, PVP, and chromosome enzymes, may be injected into the oocyte. Although the effects of injecting these substances into oocyte are not fully understood, these substances should be avoided as much as possible. Whereas in ASFI, there is no risk of injecting these substances into oocyte. Thus, a gentle microinsemination method ASFI was successfully implemented by utilizing zona-pierced bound sperm. But this brings us an important question: what about the quality of zona-pierced bound sperm? Since these sperm have not passed through the zona-pierced, could they be suboptimal? Several studies have investigated zona-pierced bound sperm. As a result, these sperm have a higher proportion of morphologically normal cells, intact double-stranded DNA, and lower DNA fragmentation. Furthermore, embryos derived from ICSI using zona-pierced bound sperm show higher developmental potential and implantation rates compared to conventional sperm selection. To be clear, this refers to ICSI, not ASFI. These findings suggest that zona-pierced binding indicates higher sperm quality. Since ASFI utilized zona-pierced for sperm selection, it is suggested that embryos generated through ASFI are fertilized with higher quality sperm. So, while ASFI resolves some of the disadvantages of ICSI, it is important to acknowledge that this method still presents certain challenges. There are two major challenges: the requirement for the zona-pierce and the fact that the fertilization rate has not yet achieved 100%. Next, let's take a look closer at the first challenge, the use of the zona-pierce for sperm selection. Although zona-pierce can select higher quality sperm, ASFI cannot be performed in cases where immature or degenerated oocytes are not available. Therefore, to expand its applicability, we need an alternative method that does not rely on the zona-pierce. So, Two approaches can be proposed to address the sperm selection issue. First, establishing methods to reliably induce the acrosomal action, and second, to identify whether the acrosomal action has occurred or not. Although various methods of inducing the acrosomal action have been reported, a method for consistently inducing it has not yet been found. Moreover, we suspect that not all sperm can undergo the acrosomal action. Therefore, we believe that it is not only to establish a method for inducing the acrosomal reaction, but also to develop a method for observing it without staining the sperm. Or at least, that's what we used to believe. However, something happened that made me question whether this thinking was correct. I mentioned earlier that the acrosomal reaction rate of the zona-pierced bound sperm was 19.8%, while there was a control group, which refers to sperm not bound to zona pierced, was approximately 29%. If the acrosomal reaction alone was sufficient for ASFI to succeed, it is speculated that ASFI could succeed in 1 out of 4 attempts, even when using sperm not bound to zona pierced based on probability. So, to address this question, we observed how frequently these sperm could attach to the oocyte membrane. As shown in the video on the left, we consider the sperm remained attached to the oocyte membrane with their tails moving to be attached. On the other hand, sperm that moved forward after removing injection puppet were considered not attached. First, all the 282 ZP sperm attached to the oocyte membrane based on the results of ASFI. In contrast, none of the sperm not bound to zona pierced attached to the oocyte membrane. So clearly, the number of attempts was too few to determine what is essential for attachment and incorporation into the oocyte. However, these results suggested that it is important to focus not only on the acrosomal reaction, but also on other contributing factors. So with this in mind, we explored various alternative methods to the zona pierced for selecting sperm capable of fusing with the oocyte membrane. First, we explored use of hyaluronic acid. Some studies have reported that hyaluronic acid-bound sperm do not undergo the acrosomal reaction. But curious to confirm this firsthand, I decided to test it myself. Unfortunately, as expected, these sperm did not attach to the oocyte membrane. Second, we attempted to select sperm using cumulus cells. In natural fertilization, sperm pass through the cumulus cells before reaching the zona pierced. However, sperm that simply pass through the cumulus cells did not attach to the oocyte membrane. Next, we focused on chemical reagents such as calcium ionophore, ionomycin, and pentoxifilin. Calcium ionophore and ionomycin have been reported to introduce calcium ions to sperm cells, inducing the acrosomal reaction. Pentoxifilin, on the other hand, enhances sperm motility. However, sperm treated with these reagents did not attach to the oocyte. And next, it has been reported that immobilization can lead to acrosome disruption. We attempted to press the immobilized sperm onto the oocyte, but these sperm did not attach to the oocyte. Thus, the major issue of sperm selection still remains to be resolved. So let's move on to the second challenge, which is we have yet to achieve 100% fertilization rate. So in clinical ASFI practice, there are cases where fertilization does not occur even when sperm is incorporated into the oocyte. This suggests that factors beyond sperm incorporation may influence fertilization. In ICSI, absence of a detectable spindle is associated with reduced fertilization rate. Therefore, spindle observation might further improve fertilization rate even in ASFI. Although further validation is needed, our preliminary findings indicate that 2PN formation rate in ASFI reaches approximately 95% when the spindle is detectable. This result suggests that ASFI with spindle observation might have a potential to achieve a 100%. In addition, as shown earlier in the ASFI demonstrating video, oocyte may still experience some stress when the injection pipette penetrates the zona persta. To address this issue, piezo system might be effective. However, I initially thought piezo system was not suitable for ASFI because several studies have reported that the equatorial segment of sperm head fuses with the oocyte membrane. Based on this, attempting to press the lateral aspect of sperm head using the piezo system was expected to be challenging due to the flat tip of the pipette. But surprisingly, when the sperm was pressed vertically, it attached and was incorporated into the oocyte. So I will now share the video demonstrating ASFI using the piezo system. This video shows the process leading up to sperm incorporation. After removing injection pipette, sperm remained attached. So this part has been sped up for clarity. Now, sperm tail has stopped moving. As you watch closely, you can see the sperm head slowly being incorporated into the oocyte. It is a very gentle and gradual process. Right here, you can see the sperm head is now fully incorporated into the oocyte. It took approximately 1 hour for the sperm head to be fully incorporated into the oocyte. So this suggests that piezo-assisted ASFI might enhance fertilization rate while further reducing the stress. So to summarize, ASFI yielded significantly higher fertilization rate and a significantly lower degeneration rate compared to conventional ICSI. Although ASFI has not yet achieved 100% fertilization rate, this method has the potential to accomplish it. If we can reliably secure the optimal sperm, there will no longer be a need to break the oocyte membrane. And when that day comes, embryologists will no longer fear degeneration, and the doctors will no longer be disappointed by it, and the patient will no longer have to grieve over it. The future of microinsemination is evolving, and together we can push the boundaries of what is possible. Let's continue working towards a future where no oocyte is left unfertilized, and every person longing for a child has a chance to welcome new life. Thank you very much.
Thank you for your great presentation, Dr. Hatakeyama. Now the floor is open for discussion. Any questions from audience?
Sure, pardon me, Yaku from Israel. This is fantastic. For scalability, have you thought about maybe inducing the protein, the Juno receptor, and trying to activate acrosomal reaction without needing to bind it to zona pellucida?
So do you, just to clarify, do you mean that some protein?
Yeah, so the attachment is
Yes.
to the Juno receptor on the zona pellucida.
Yeah.
So if you can create
Yes,
the protein and just add it to the media, would that be sufficient? I'm just wondering.
Yes, there is a possibility, but so we hypothesize that some presence of certain protein, like ISMO, maybe more important than acrosomal reaction itself. So if we can reliably secure some binding proteins to sperm, it can be fertilized without zona pellucida. Thank you.
Krzysztof Lukaszew from Poland. Did you try Sendai virus for fusion?
No, I've never tried it.
I
have a question, please. I would like to hear your idea about this. Zona attachment, for example, is a challenge, crypto, or just one sperm collection. For such a challenging situation, do you have any idea to overcome a tight situation like this? May I answer in Japanese, or should I speak in English?
Our experiment, in about 5% of oocyte retrieval cycles, we did not obtain zona pellucida bound sperm. In that case, we cannot perform ASFI. So instead, I performed ICSI. So in current approach, depend on the zona pellucida. So if we can reliably secure sperm such as unable to attach the oocyte membrane without using zona pellucida, so it can be more adaptable. But this is subject for the future investigation. So it's just one oocyte. We did not perform ASFI.
ありがとうございます。また後でゆっくり聞かせてください。ありがとうございました。
For your response.
時事医大のバイオシの上條です。
エンブロロジニストガヨガ from GT University.
In space oocyte. In this oocyte, how inject the donor pellucida and choice peritoneal space in ASFI.
Thank you. Good question. So, in the case of with narrow peritoneal space, it may be challenging, but it is not impossible to inject the pipette into the peritoneal space. But it's practice so required, but it can be. And so, basically, we inserted the wider space, peritoneal space, but we press the sperm, avoiding the vicinity of the polar body and detectable spindle. And so does that answer your question?
ありがとうございます。
Thank you for lots of questions. We are running time, so we close this seminar. Thank you. Thank you for your attention. Thank you, Dr. Hatakeyama.
We would like to express our sincere gratitude to Dr. Hatakeyama for his lecture and Dr. Ohgi for serving as chairperson. Thank you very much. This concludes the Luncheon Seminar 5, co-hosted by Reproductive.